Okay, well, hello everybody, and welcome to the third in the series of weekly webinars being organised by the Global Platform for the Rapid Generation and Transfer of Knowledge on COVID and older people in low and middle income countries. We've got a range of different activities, and most of them you can find out about on this website that I'm sure most of you are already familiar with. But if you're not, do check it out, because we're doing a large number of different things. Who are we? Well, we're an informal, almost entirely unfunded network of academics, stakeholders, and practitioners. We're not exclusive to a specific university or institution, and we're mainly run by volunteers. We have had a small amount of seed money from the University of East Anglia, but this is not, as I said, a university-specific intervention. The idea being that we want to include as many different organisations and individuals and be as embracing as possible. So we run these webinars. We've got a website. We publish several blogs a week. We're looking for support to keep this initiative going because, as I said, this is almost entirely unfunded, and I don't think it's going to be very easy to sustain this wide range of activities over the next few weeks unless we're able to get some additional support. Our webinar last week was on ageism, health, and coronavirus, and we had over 200 participants, and it was extremely interesting. And one of the things that came out of that was that many of the participants were very enthusiastic about the idea to form a specific group related to ageism and coronavirus, not necessarily exclusively focused on low and middle income countries, but perhaps with a more global remit. And that's something that I'm going to report back after the webinar today. I'll take a couple of minutes to report back about where we're going with that. And I'll also share with you the lineup of the webinars that we're hoping to run in the next month in May. So I'd like to go to the topic of today's webinar, which is older people, comorbidities, and coronavirus in low and middle income countries. And I just, as a provocation, I came across this quote from a senior British politician who used to be our Home Secretary a number of years ago in a debate taking place the day before yesterday, where he was criticising the potential decision to have a lockdown specifically for people aged 70 or above. And I'm sure many of us would have many reasons for being against such an age-specific lockdown. But what I found very interesting was that he stated as fact that age itself is no longer a risk factor unless underlying health conditions are attached. And that just shows the degree of misinformation that's out there, I think, in terms of the relationship between age as a risk factor for coronavirus and other health conditions, and how those interact. And that's just one of the issues, the relationship between comorbidities and risk of infection and risk of fatality from coronavirus that needs to be thought about. Of course, we also need to think about how coronavirus itself can affect those other health conditions, both in the immediate term and in the much longer term, and more complex interactions in terms of policies to deal with coronavirus, and how those affect older people with complex multiple health conditions, different needs. For example, how does lockdown affect people's access to treatment and medication, which can have many knock-on effects? So there are, even just focusing on the specific topic of older people, comorbidities, and coronavirus, there are 101 different questions that we could be addressing today, and they're all very important. I'm going to hand you over to my colleague Janet Seeley from the London School of Hygiene and Tropical Medicine, who I feel is probably uniquely placed to help steer us through this complexity. I think she's uniquely placed because she has a very long and prestigious record of working on a wide range of different issues from different disciplinary perspectives. She's an anthropologist, but she's also very comfortable working with epidemiological research. She has a strong background in ethics, and of course, many of the issues that we need to try and get our heads around at the moment have a very strong ethical dimension. One of her original research focuses was on HIV/AIDS and infectious disease, but increasingly over the year, she's also looked at chronic diseases and non-communicable disease, not just older people, but increasingly older people. And she has extremely large amounts of experience working in different parts of sub-Saharan Africa, in Uganda, in South Africa, but also historically she's done a lot of work in South Asia as well. So I think her geographical expertise, her expertise in terms of chronic disease, infectious disease, and the different combination of disciplines that she's been able to bring to bear on these issues means that she's a fantastic person to be able to manage this very complex set of issues that we're going to try to grapple with today. So without further ado, I'm going to hand over to Janet, and she's going to moderate the rest of the webinar. Thank you, Janet.
So thank you, Peter. And without indeed any further ado, let's go straight into our first speaker, Vivekanand Jha, who's going to talk about healthcare services for older patients with chronic diseases during the COVID-19 lockdown in India. So 15 minutes, Vivek, I hope, and I'll hand over to you.
Thank you very much, Janet. Can I have my slides up, please, Lucas?
Yes, just a second, sorry for the transition.
While Lucas puts up the slides, the first thing that I have to do is to thank the organizers for inviting me to talk to you this evening on this topic, which has practically taken over our lives for the last few weeks or few months, depending on which part of the world you live in. And the conversation around COVID refuses to die, not just because it is an important issue, but it's become, it has brought new terms into day-to-day parlance. And just before start of the webinar, we were talking that until a few weeks ago, most of us did not know what PPE means. But now there is hardly a person, at least in our circle of acquaintances, who wouldn't know that. So thank you once again. And the topic that I'm going to say something about in the next 15 minutes or so is around healthcare services for older patients who have pre-existing chronic diseases, and how is the current COVID lockdown affecting them. And I'm going to use India as my frame of reference. Can I have the next slide, please, Lucas? As you just heard, this is something which I'm not breaking as a secret to you, that people who are over the age of 80 have the highest death rates if they have COVID and if they get to a hospital. And this increase in rate of deaths according to age is pretty much increasing from the time you get up to about 40 years old. Now, the other fact also, which is well known, is that people who have pre-existing medical conditions also have an increased rate of risk of death. And you can see that people with pre-existing cardiovascular diseases have almost 1 in 10 risk of dying. And diabetes has about 1 in 13 to 14, and so on, which you have on this particular slide. And this data is from United States. But if you see on the next slide, please, Lucas, the data is more or less similar from when you look at death rates from China. And here you have another variant included, which is sex. So males have an increased risk of death if they get COVID. And based on these two, I think what is, again, important to emphasize that age itself is not a risk factor for getting the infection, but it is for death from the infection. And a lot of it is due to interaction with pre-existing health conditions. And this becomes more clear in the next slide, which shows you the interaction between deaths and underlying conditions from a cohort in New York. So in the first column, you have age range, starting from 0, going up to 75 and above. the number of deaths that were seen in different age groups in New York, and the one after that is the proportion of deaths, and then the subsequent two columns show the number of deaths with underlying conditions and without underlying conditions. And if you look at even the very first row, that if someone has an underlying condition, even when they are 0 to 17-year-old, the risk of death increases. And the same pattern persists down the list of rows and going up to the highest age group, that if people have an underlying health condition, their risk of dying increases, and they make up most of the numbers who are dying. And that is one of the explanations that has been given about the large number of deaths in developed countries, because they just have a large proportion of older people. And so that takes us to looking at how the populations are distributed in different parts of the world. And so if I can have the next slide. So if you look at the population pyramid, I have put two countries. One is my country, which is India on the right. And the second one is the country which from which you saw the data in the last slide, which is US. And you can easily see that starting from below upwards, that the number of young people is much, much greater in a country like India compared to US, where you can see that the bulge continues until very late before finally tapering down to a top. And so just that the larger number of people in a country like US, and the same is true for many other developed countries, are relatively old compared to a country like India, which is still emerging, and large populations in sub-Saharan Africa, for example. Can I have the next slide, please, Lucas? So let's just talk now about the Indian elderly. So what are the unique issues with Indian elderly? Some of them are shared with elderly anywhere else in the world. There are social issues, for example, loneliness. In India, of course, elder abuse has been reported quite a bit. Elders are neglected in households, even when they live in large joint families, because of a number of reasons, because of social issues, but also because of deprivation. When there are issues or resources for which there is competition, often the elderly are the last ones to get benefit of those. Elderly, of course, do not have income security as much as a younger person who is earning has. And elderly have already a very poor access to healthcare. Some of it is related to fundamentally weak healthcare system in India, but also the rest is related to sharing of limited resources. And again, elderly get cut out much easier than a relatively able-bodied younger household people who are earning members of their family. In Indian healthcare system, there is a lack of policies around a number of things, such as advanced directive, palliative care, end-of-life care, which is now pretty well understood in the developed countries. So what has been the response of the government or the healthcare system to these issues? So a few years ago, the government of India put out a national policy on senior citizens, which of course is still in development and needs to be fully fleshed out. There are a number of non-government organizations that take care of the elderly through old age homes and by specific programs to take care of the elderly people. And in some states in India, for example, Kerala, they have started developing palliative care units. Kerala is one of the states in southern part of India, which is somewhat more developed in terms of its healthcare system. Can I have the next slide, please? So now let's turn to non-communicable diseases. So I think it's really important to put some numbers, and it would surprise you to know that more than 10 million people would have died in India just in the last 1 month, during which we have had a lockdown in place because of cardiovascular disease. Now, why is this number important? It's important to keep this in mind because while we are trying to prevent coronavirus deaths, in India there have been a few hundred coronavirus deaths so far, we are missing in this context even talking about these large number of people who are dying already of pre-existing conditions. Next slide, please. So what what has the lockdown meant really for an Indian in terms of his or her ability to access the healthcare system? So what the lockdown has meant is the shutting down of public transport, the shutting down of regular services in hospitals. Many hospitals have actually been taken over by governments and designated as COVID hospitals. And so they're no longer providing routine services to its customers. These are large number of public sector hospitals, but many private hospitals as well. And then there has been a severe impact on drug supply chain, consumable supply chain, which has meant that many people who require regular supply of drugs for chronic disease management are unable to get their drugs, or people who have to access specialized services, for example, dialysis, which is something I know about because I'm a kidney doctor, are really suffering because they are unable to get to that. And we'll talk a little bit more about that, because that is one of the exemplars of how chronic disease care is suffering. There are many doctors who are now not available because they have been put on COVID duty, and healthcare resources being really rationed. And this is not only doctors, but also other healthcare professionals, nurses. So people have been now placed on rotation duties. So they get to stay at home for a week or 2 weeks before being called back to duty, because they are being protected to take care of patients who might show up with COVID infection. People have had challenges with getting their medicines. And then, you have a large amount of disinformation going on social media, especially WhatsApp and Facebook groups, with the peddling of fake cures, both for COVID and for how to protect himself or herself against a person against COVID. So which is creating a lot of confusion and pushing people in directions you don't want them to go as a healthcare professional. People are not able to, of course, keep their healthy lifestyle. They are not allowed to go outdoors, so they can't do any exercise. They are not able to access healthy food. In fact, for a large number of people in India, access to even any kind of food has become really very difficult. And finally, many people have even no access to money because they are out of jobs. They don't have any savings to fall back on. And so as a result, one of the first things that they start cutting down on is medical care, because they can't afford to cut down on food, especially for their family and for their children. Can I have the next slide, please? All this has a tremendous effect on the care of people with pre-existing conditions, especially people who are older, already disadvantaged, and have pre-existing conditions. I'm not sure if you have heard of this. This is something which was quite unique to India, and I suspect might have happened in some other developing countries as well, is when the government of India announced a lockdown quite suddenly. A large number of Indians who depend on their earnings by work in informal sector, for example, construction business, or as daily wages workers in various small businesses, they certainly found themselves out of a job. Since they did not even have a regular place to live, they certainly couldn't find a place to sleep. Since they were out of a job, they had no money, and so therefore they had no food to eat. And they find that they were kind of unable to live where they had been living so far. And they had no choice but to try and find their way back home to their villages, wherever their families were. Public transport had shut down, so they could not even get back to their villages. And what started happening is large number of people, as you can see in the picture on the bottom, who started just walking back from wherever they were working back to their homes. This took a huge toll, both not only in terms of their physical health, but also in terms of their emotional health, in terms of their ability to maintain a dignified lifestyle, and so on and so forth. And on top of that, they were often treated quite harshly by the law enforcement authorities who were trying to enforce a lockdown. And they saw that these people were moving in a sort of a caravan. And of course, their ability to access healthcare was the last thing on their minds. Can I have the next slide, please? So I'll now tell you a few examples from my own specialty, which is dialysis. And as I said, dialysis is a service which a person with kidney failure needs to get 2 or 3 times every week on a regular basis. So they have to travel from their homes to a dialysis center, access dialysis, and then go back. So it requires their being able to find transport to get to a dialysis center, for the dialysis center to have enough staff, enough consumables, enough supplies. For the dialysis staff to be able to take care of these people, they should have access to PPEs on a regular basis, and so on. So there were a number of challenges which conspired together to affect care of dialysis patients. And as a result, in this tweet, which is right now on your screen, you can see a news report which says that a dialysis patient died, because a number of dialysis units had closed down, and these dialysis units had asked their patients who were getting dialysis to go and get dialysis in another unit. And when they went to a second unit, first of all, the second unit did not have any extra capacity. Even if they had, in some instances, they asked this patient to go and get a COVID test. And in this whole process, the patient actually died, because you need to if you have kidney failure, you do need to get dialysis every third day or every fourth day. Otherwise, your life is at risk. And can I have the next one, please? And then, you can see that a large number of NGOs, including the research groups that we work in, also, swung into action, and they started providing transport to these people. And it is as a result of these concerned citizen groups that a large number of patients with chronic disease have been able to receive some medical care. Next slide, please. So a group of concerned citizens who call themselves COVID-19 Kidney Health Action Group came up with a list of checklist to help dialysis units prepare themselves for managing patients with dialysis who require dialysis during this particular period of time. And this is just an example. Groups in the organization that I work have actually put out a number of other similar advisories which are helping different cadre of healthcare workers and different healthcare services to continue providing chronic care to people who need that kind of care. Next one, please. And I said something about the fake news, and so there is a lot of fake news going around, which even peddles fake cures. Next one, please. And what that has done is also really confuse the people. During this time, even healthcare authorities and some responsible bodies have not necessarily covered themselves with glory. And that story we have heard and seen, in fact, playing out in many countries, including US and even in UK. So even the Indian Council of Medical Research, which is one of the top funding bodies in India, sometimes came up with, in their anxiety to try and protect the population, and they thought they were giving good advice, but they came up with some completely non-evidence-based advice, which one such example was their recommendation to give hydroxychloroquine to every asymptomatic healthcare worker with the hope that it will protect them from giving coronavirus infection. But what it did, next one, please, was to...
Vivek, could I just ask you to hurry up a bit, please? Thank you.
Yes, thank you. I'm almost done. So it reduced the supply of hydroxychloroquine from the market, and hydroxychloroquine was suddenly no longer available for people who required them for its treatment. For example, those with systemic lupus erythematosus and rheumatoid arthritis, which is causing their care to fall into serious jeopardy. Next one, please. Can I have the... Yes, so recognizing this, the World Health Organization, and this is a fact sheet from PAHO, which is the arm of the World Health Organization in Latin America, has made some recommendations about what to do for patients with non-communicable diseases during COVID-19 pandemic. And next one, please. So just to say that the elderly are particularly vulnerable, and their vulnerability has been shown up quite in stark ways during this COVID pandemic. And we need to make sure that while we continue to talk about COVID, we don't forget the plight of people who have pre-existing conditions. And this group of people, obviously, because pre-existing conditions, non-communicable diseases, go hand in hand with increasing age, are most likely to be in the elderly age group. So I'll stop here, and I'll again thank you to the organizers for giving me this opportunity.
Thank you very much, Vivek. And just to point out that you'll see at the bottom of the screen, there's a Q&A button, so you can put your questions there, and we'll bring them together at the in the last 25 minutes so that people can get some answers from the panel. So I want to move swiftly on to Moffitt Nirenda, who's from Malawi, working with us in Uganda at the moment, and is also, like me, at the London School of Hygiene and Tropical Medicine. So Moffitt, please.
Thank you very much, Janet, and thank you very much for the invitation. It's really nice to take part in this very important webinar. Next slide, please. So I think, next slide, please. So I think although COVID is relatively new, I think we're beginning to learn a huge amount about this condition. And we know that it is transmitting very fast, and that's why we're also worried about it. But overall, I think fatality is relatively low, but for something that gets transmitted so fast, it is worrying. But even in these early stages, the evidence that has come from China and more increasingly in Europe and America, as Vivian has alluded to, suggests that individuals that are older and those who have chronic conditions, particularly non-communicable diseases, are at greatest risk of having a severe disease or indeed dying. And with risk ratios ranging from a 1% if you have a no underlying condition to up to 10% if you have a cardiovascular disease. We don't know what is responsible for these excesses in risk. It may well be that these individuals have got weak organs, immunodeficiency has been implicated, as has been excessive inflammatory responses. But regardless of the underlying mechanism, the association is becoming quite solid. And I think the most important thing is that it's both comorbidity or multimorbidity as well as age. And so in as far as Africa is concerned, I think we are the last continent to be hit, but the disease is clearly escalating in a very alarming rates, at least in some countries. In Uganda, we are very lucky because the government has been very, very diligent in terms of the communication, in terms of the processes that have been put in place to try and contain the spread. We are in a very strict lockdown, and transmission so far has been imported cases, initially with people coming from Dubai, the UK, and other places. But more recently, it's importation from lorry drivers that are coming from Tanzania or Kenya and other neighboring countries. But in general, from within Uganda, and as far as we can tell, the transmission within the community seems to be relatively little. And at the moment, the total number of cases is 75, and between 40 and 50 of those have come from the UK and other countries via the planes, and the majority have been from Tanzania and Kenya. Next slide, please. So when we talk about NCDs, old age and things like that, what comes to mind in most cases is the age structure. As was alluded to earlier on, most people tend to think that with the population structure in low and mid-income country here represented by Kenya, in comparison to the United States and Italy, that we have a very broad base. So most people are young, and therefore the assumption is that these countries should not have as much of the NCDs. But if one looks at the sheer numbers in terms of the population size, actually there is a lot of people who are older in low and mid-income countries. So indeed, 75% of individuals aged over the age of 60 years live in low and mid-income countries, which will include Africa. And more importantly, there is increasing evidence these days that these chronic conditions and their increases in numbers per person, much morbidity, tend to occur at a much younger age in low and mid-income countries, including our own data in Africa. And so it's not surprising, therefore, that the majority of the global population with NCDs reside within low and mid-income countries. So I think we should not be forgotten when there is debate about aging and a multimorbidity in low and mid-income countries, because all the evidence suggests that the burden is actually out here, if anything. Next slide, please. And in the next slide is just my cartoon of trying to emphasize this point. And we know that these conditions, NCDs, are supposed to be degenerative conditions and therefore conditions of aging. So part of the normal aging process. If you age, you are more likely to have these comorbidities, metabolic disease, neurodegenerative disease, cancer, impaired bone health, and things like that. Next slide, please. And the way that we've explained this is the traditional risk factors that, you have a poor diet, excessive alcohol intake, dietary indiscretion, physical inactivity, smoking, air pollution. These are traditional risk factors that we know about that would accelerate your aging process and therefore contribute to morbidity. But in countries like in Africa and other low-income countries, there are also exposures earlier on in life, particularly under nutrition, including when it occurs before you are born, prenatally, that these exposures can actually, in ways through perhaps epigenetics, but other mechanisms as well, they can actually influence how your body develops, and in a way that you might actually age precautiously. So for example, the size of your organs may be small, and therefore you may not be able to compensate as much as you grow. So for example, there is a lot of data that was, those were championed by David Barker in Southampton, which showed that, next slide please, that babies that are born with low birth weight, they have a much higher risk of having hypertension or diabetes when they're adults. So something that happens earlier on in life can predispose you to these long-term adversities in terms of NCDs. Next slide, please. And when people have looked at hypertension, for example, you can actually pin it down to the very molecular or organ size evidence. So for example, this slide there, that graph is just showing how if you are born with low birth weight, you have much smaller kidneys in terms of how many glomeruli you have. And therefore, if you've got a small kidney, you are more likely to have hypertension as you age. So you've got a small organ, and therefore you are more likely to have these degenerative conditions at a much younger age. So this may well explain why these conditions in Africa, at least, because we still have these exposures, are occurring at a much younger age, and in most cases in people who do not have other risk factors like obesity. Next slide, please. And it's not just about what happens before you are born, it's also about what happens continuously as we age and the other exposures, and notably infections, particularly chronic infections that have a lot of inflammation around them, and these contribute to aging of the cells, and this has been demonstrated in HIV, for example, that individuals with HIV have much more reduced telomere length, which is a biological marker of aging. So HIV-infected individuals are more likely to have these comorbidities at a much younger age. And then we add in the effects of treatments like ART, which will make people age much more prematurely. I'm emphasizing this because I think we need to move away from a chronological age in itself, but instead someone's ability or other elements, functional elements to assessing age, and sometimes we overlook that. And I remember there were a lot of interesting data from this age work, which showed that if you compared grip strength, for example, which is a very good marker of aging, among Africans versus Americans, Africans have a much lower grip strength compared to the Americans at the same age. To a certain extent that an African would be 10 years older compared to an American if you merely used the grip strength as a measure of that aging. Next slide, please. So beyond the confounding of early life events as well as a chronic infection and inflammation, there are other specific challenges, I think, that we need to look at when we look at NCDs and aging within the context of Africa. And one is poverty, both because it brings in it undernutrition and infection, which are in themselves a comorbid conditions when it comes to non-communicable diseases. But I think more importantly, because of the a potential cost that they bring, in terms of a catastrophic expenditure on NCDs. And I think the other element has to do with cultural practices. So some of the practices are obviously good. We have extended families which have been very helpful before, although those are now being strained and therefore they're disappearing. You also have this concept of where you retire and therefore you go to the village. And in the context of COVID, I think the villages are probably much safer places to be than townships. So those cultural elements would be protective and are supportive. But there are also a lot of other cultural practices that are particularly bad, particularly when it comes to older people. And I'm thinking of how someone may have stroke and they will be associated with witchcraft, will be stoned. And this is increasingly happening in a number of countries at the moment. I know my own country in Malawi, we are trying to deal with this issue of bloodsuckers and the people who kill other people. And in most cases, it revolves around older people and they're suffering quite a lot. So I think these cultural practices are important to take into account when we look at NCDs. And the other element that I wanted to raise is that of health literacy, which is absolutely a major problem in Africa. And that in itself then limits how empowered people are, particularly older people. And that, these elements will also limit whether individuals have access to healthcare or not. So for diabetes, hypertension, for example, less than 20% of individuals with these conditions will have access to healthcare, which is really, really challenging. And so even if you do get to your health center, the service that you get there is not going to be absolutely optimal, particularly because these systems are designed for treating malaria and pneumonia, episodic conditions, not for chronic care, although nowadays we are gaining experience with HIV, but most of the systems are still very much designed and revolve around acute episodic care, which is a major challenge. So I'm emphasizing all this because I want to make a point that with NCDs, if you live in places like Africa, then you already start from a very, very disadvantaged position even before COVID comes in. So NCDs at the moment are very poorly managed, and therefore these conditions within the context of Africa are very, very poorly controlled. So you add COVID to this, the situation will be very detrimental. Next slide, please.
Is this your last slide?
This is my last slide. Yeah, is that okay? So this is just to say what impact will COVID have. I think the impact will be huge because, as I said, we already start from a point where the systems are very weak, not responsive. So when we've asked around, no one has prepared in terms of how clinics will be rearranged to make sure that people can still continue to receive care. There is no mention of how the drugs might be delivered in an imaginative way so that people can continue to receive medication. So when there is lockdown, it's locked down in its entirety, and therefore people are basically just locked away from any form of a health system. So the outcomes will be catastrophic. And more importantly, governments are diverting resources from programs that are in existence towards COVID, and therefore these programs, which were already suffering, will suffer even more. And my feeling is that we'll end up losing quite a fair amount, even the tiny gains that we started having or seeing in terms of how NCD care is provided. Those will be swept away. And so, although we don't have all the information or trying to engage in research in terms of what impacts might come through with COVID, I think one can guess that the impacts will be huge. But I also hope that through this hardship and the research that will come in with COVID, we'll probably learn a lot and be able to be in a much better place in terms of preparation if something like this comes later on, because I think Uganda is probably doing better than other surrounding countries because it has that experience, particularly with Ebola, and therefore we've learned from that. So I really hope that, through this suffering, we'll hopefully learn how to respond better if something similar comes up. Thank you very much.
Thank you very much, Moffat, and we particularly like the evening birds in Uganda that are singing to us.
Sorry.
So we now turn to Sivana Aladi from Bengaluru in India, and Sivana is going to talk to us about dementia. So I'll hand rapidly over to her. Thank you.
Hello, a very good afternoon, evening to all of you. Can I have the next slide, please? Right. So for some reason the title slide hasn't come, but that's fine. So the topic is dementia and COVID-19, perspectives from South Asia. It's a tall call to talk about one perspective from South Asia, but it's an important perspective because we constitute about 1/4 of the world's population, making it the most populous and most densely populated geographical region in the world. The other characteristic about South Asian countries are that they have large inequalities in living standards, in life expectancy, and access to resources because of differential economic and social changes in the country. Next, please. What is also unique about South Asia is that we are a very diverse community. We have very diverse communities. There are more than 600 languages that are spoken here. Many religions of the world have originated here. We have both very high functioning literates and illiterates. Can I have the next slide, please? So we are on this cusp of modernity and tradition. And I think this socio-cultural milieu that we are in is likely to impact any health problem that we face. Next slide, please. So I work with patients with dementia with interest in public health as well. And what is interesting is while I was training in neurology, this is just about 25 years ago, a door-to-door survey reported that patients with dementia were not found in the mountainous areas of Kashmir. This was probably a combination of a relatively younger lifespan, socio-cultural protection, as well as low awareness about dementia. Next slide, please. But what we've come to now see is that the burden of dementia is indeed the maximum in low middle income countries. In India alone, there are about 5.2 million people with dementia. And you can also see that the burden is rising in developing countries while it's actually stabilized in the West and high income countries. Next slide, please. So in the situation of large numbers of dementia, a relatively new problem, a younger disease for our countries, how is care organized currently or before the corona epidemic? There was a low awareness about dementia with the stigma, and that was associated with a delay in diagnosis. Majority of people with dementia still are provided care for in their own homes by their families. For a population of about a billion, there are just about 100 memory clinics across the country. Trained professionals, be it doctors, nurses, social workers, speech therapists, professional carers, are very few. There are about 15 or 16 long-term care centers and a very, very small number that have people, about 50 to 60 people per center. Psychosocial support provided to informal caregivers is limited. So basically all that this leads up to is that proportion of people that as a healthcare system we are even addressing is just about 10% of people with dementia in the country. Next slide, please. I think you have the older version of the presentation, Lucas. Lucas?
Sorry, I have the one that was sent to me.
No.
Would you like to share your own? And
can I do that? Yes, I will do that. Thank you. Thank you very much.
I'm going to stop sharing. Just,
yes.
I apologize.
No problem. This one. Can you see my screen? Can you see my screen?
Yes.
You can, yeah.
Okay, sorry about that. And I think we made a quick change. And finally, in this background of very few very little support that is there for persons with dementia, cost of care is also very high, and nearly 64% of expenses on medical care itself come from out-of-pocket expenditures. So therefore, when we're talking about a South Asian perspective, we're talking about a high disease burden in a diverse socio-cultural milieu, in the background of limited resources, and considering the number of people we are seeing very little evidence about what is really happening. And in this background, we have the COVID-19 pandemic. Numbers suggest that there are about 36,000 people with COVID-19 infection in South Asia with 1,500 deaths. And in India, the first 3 cases were reported in medical students on 30th of January 2020. The first death was in a 76-year-old man with comorbidities and history of travel. And today, as we speak, there are about 17,000 persons with COVID infection. 718 deaths. And you can see from the map of India that the disease burden is extremely variable across different states. So it's not just one country, it's a subcontinent really. And states that have a lot of high density of people with travel history are affected more than the others. So making management that much more difficult. And culturally, we have low awareness about the spread of disease. Intergenerational families are living closely together. And as mentioned by the previous two speakers, we have the unfinished agenda of infectious diseases, nutritional diseases, and the super added endemic of non-communicable diseases, right, increasing the levels of comorbidity in upper elderly people with dementia. So we are clearly unprepared for the pandemic, and this has exposed many of our vulnerabilities, medical, social. So being a neurologist, I thought I'd say a little bit about how the COVID-19 virus affects the nervous system. Well, it can affect the nervous system, although it's primarily a respiratory infection. Cognitive impairment is likely following after COVID-19 infection due to encephalopathy, stroke. The SARS-1 produced long-term psychiatric and cognitive disturbances. It's not yet clear if COVID-19 will, it probably will. And persons with dementia are vulnerable because they're older, they have a higher mortality. If they develop the infection, they have loss of support systems and their own lack of understanding of the disease. For example, people with dementia communicating and a worsening of behavior, and with stress among the carers, they're likely to mirror the stress and therefore cause more behavioral problems in them. The loss of continuity of care is what is the biggest problem for persons with dementia today. So what are the consequences on dementia care? While lockdown and social distances are indeed crucial, this has resulted in discontinuity of social care, medical care, rehabilitation, increased burden on family carers, limited help from professional home carers on whom we depend upon so much. Daycare services have been stopped, support group meetings, community awareness programs have also stopped in person. Long-term care facilities have dwindled in their staff. There's difficulty in accessing medical services for comorbidities with uncertainty about the future. So there's clearly an emerging need to adapt existing services for persons with dementia. The good news is the government has been extremely proactive in all these countries. The Indian government has provided a health advisory for elderly population during the pandemic through the Niti Aayog, which is a planning think tank of the country. There are several ways in which they have disseminated information. There are directives for protecting people with disability, and there are training programs for medical professionals and other frontline workers, and efforts are being made to support low-income households as well. This is the app that has been developed by the Ministry of Health. It's called the Arogya Setu app. Basically, Arogya means health and Setu means bridge. It's meant to connect essential health services, people from the government, with society, with healthcare workers. So you have three systems trying to, being bridged with this app. Hospitals, like where I work, we are providing service for our patient population, guidelines on how to care for elderly with dementia. NIMHANS, where I work, is a premier neurology and psychiatric institute. There is a massive telemedicine program that is being done here for providing mental health care as well as support for carers with dementia. The Indian Academy of Neurology conducts series of webinars. Our clinic provides support as well. But more importantly, we have strong NGO support from our country. The Alzheimer's and Related Disorders Society of India, ARTSI, just founded in 1992, has 20 chapters across the country, and they have been very actively involved in providing support in general for dementia. And during the COVID days, translation of existing services into online modes. So this is ARTSI Hyderabad, which is conducting a Zoom meeting for its carers. And there are WhatsApp groups where there's an active discussion to support carers and elders during this period. ARTSI Mumbai, ARTSI Kolkata, in the print media, on Facebook to boost the morale of dementia families. The other NGOs, the Nightingale's Medical Trust, is one of the few long-term care providers in India. And when we speak to the administration, Dr. Radha Murthy, she says they're needing to allocate resources for providing cognitive stimulating therapy, to maintaining hygiene among persons, among the staff itself. They're understaffed, but they are constantly motivating their staff to provide care for people in their residential care systems. You can see Prem Kumar Raja here tweeting to the Prime Minister, raising awareness for long-term care in the Indian context. They've also been very fortunate. A lot of advisories have come from international support organizations. The Alzheimer's Disease International has released a position paper. Alzheimer's Association of America has provided a lot of guidelines, and STRIDE, which is a 7-country research program on improving quality of dementia care in the world, strengthening responses to dementia in developing countries. They have also been very proactive in disseminating information about dementia care. Some positive observations from this is that clearly we value our elderly. So traditionally, the older people, we're hanging on to them really, and we really do not want them to fall sick. So there is a lot of effort in protecting them. Our cultural practices of addressing stress, talking to people, yoga, meditation, they're all coming up as ways of dealing with stress. And I think what is most reassuring is, in a system where the medical was very separate from the social and from the policy in public health, this is probably one of the first few times when they've actually come together. Doctors are talking to public health experts, policymakers are talking to healthcare workers, and society is in touch with both. And this, I think, is something that is heartening to witness. I spoke to one of our persons with dementia, the carer, and she said, I haven't spent so much time with my husband with dementia. I'm noticing a lot of problems that he has, which I didn't before, but at the same time, I'm able to address them. But really, social isolation is not very good for persons with dementia. So there are some positive observations, and there is an opportunity to reframe care with a new version of existing models of service. We don't know what will come. Particular webinar has been so good for us to organize our thoughts, contact all the stakeholders for dementia in India just to prepare for the seminar. And it's important to be prepared and anticipate emerging problems, to be alert about the dynamic situation of COVID-19, to align closely with the exit strategy of the government, which will probably come in a few weeks' time, and to adapt and transition all existing services and support for persons with dementia to the new normal. This will clearly require close collaboration, coordination between all stakeholders, and development of a strategy that can protect interests of persons with dementia and their families. Finally, to conclude, in the South Asian context, it's important to understand that understand COVID and dementia in a framework of high disease burden, a public and health social care system that is already strained, and in the context of significant diversity in socio-demographic and cultural factors. The variability in healthcare systems, a potential worsening of the economy, and unpredictability of future in a dynamically evolving situation will add to this impact. So there's an urgent need for all stakeholders to come together to reimagine dementia care, adapt services to the prevailing situation. The hope and opportunity lies in the dissolution of traditional boundaries of medical, social, and policy, as are evidenced by the efforts that are going on in India today. So with that, I'd like to thank you. There's a list of references, but these are the various stakeholders that are currently engaged in coping with the problem. Thank you.
Thank you very much. So what we're going to do now, we've got 6 questions, or actually about 4 questions and a few comments in the question and answer slot. So I'm going to ask the speakers to consider the questions. I'll just quickly summarize those. And then Max Bachmann from UEA will give about 5 minutes of comments while the panelists get a chance to think about answers. So, and please do carry on putting up questions. So I think there are a couple of questions, Vivek, particularly asking around the ratio of palliative care hospitals to home in Kerala, and then also pointing out that India has donated chloroquine to Mauritius. That's more of a comment, but asking if there is evidence, I think this particularly in India, and perhaps Savannah and Vivek can comment on this, evidence on deaths by class, age, gender in the settings. And then a comment really asking, reflecting back on the impact of COVID on the different lower middle income countries by age, and really, the risks for older people of NCDs. But I think Moffat may want to have a comment about that, given the attention he's drawn to NCDs affecting people at a younger age in some African countries. But I think then a point, particularly for Savannah, who's been talking about the really interesting interventions in India using telemedicine, is really how can that reach impoverished people in slums and rural areas. And I think that's also a comment that the other speakers may want to reflect on. So while you give a little bit of thought to those questions, Max, can I ask you to give your remarks?
Thanks, Janet. So I'll show my face. So very briefly summing up, we've had a wide range of inputs from around the world, showing some of the main problems of the COVID epidemic on older people. And these include problems of how the lockdowns have aggravated or reduced access to health services, how problems have particularly arisen for older people. We don't have a lot of data, and most of the data we have from around the world is actually quite inaccurate. Recent evidence suggests that the numbers of deaths that are being reported and attributed to COVID infection are probably underestimating about half of them. The latest mortality statistics from England and Wales, for example, are revealing. Now, the UK has a lot in common with other low and middle income countries with regard to the fact that there's very little testing for COVID infection outside of hospitals. So what are considered deaths definitely due to COVID infection are probably greatly underreported. So the latest data we have show that the total deaths per week were about 76% higher than they were for the same months in previous years. So almost a doubling of the death rate. And that suggests, if that excess was largely due to the pandemic, that we're underreporting by about half of deaths. But particularly important for older people, over a quarter of all deaths were in care homes, and deaths in care homes were twice as common as they were just a month earlier. The other quarter of deaths were deaths at home. And interesting, the causes of deaths, the most common cause of death was dementia, and dementia, heart disease, and stroke made up 30% of all deaths, whereas coronavirus, chronic lung disease, influenza, and pneumonia made up the other 20%. Meanwhile, in the UK, there's been a 30% decrease in people visiting emergency units, and that probably accounts for many of the excess deaths that are happening outside hospital. As we've heard from Professor Jha and Dr. Ali, there have been, and Prof. Nurenda, been great reductions in access to hospital services in South Asia and in sub-Saharan Africa, and the lockdown is creating great problems with this regard. So these figures suggest older people are not getting the care they need, and that inadequate treatment of severe and acute conditions is probably counting for a big increase in mortality. But also important is the lack of control of chronic conditions, with which Prof. Nurenda emphasized, and showing how the COVID pandemic and the fact that people with comorbid chronic conditions are most likely to die following COVID infection, it's really drawing attention to the importance of control of chronic NCDs. So today's talks from around the world highlight some of the main dilemmas we face in providing healthcare for older people. They involve setting priorities, making trade-offs, and balancing risks, as we've heard today. So some of the dilemmas we face are, is it more important to control the risk of COVID infection or to maintain access to healthcare? And both those questions are particularly important for older people. Should we prioritize using health service resources for dealing with COVID or for management of other conditions? Should we prioritize acute, severe, life-threatening conditions or prioritize maintaining control of chronic, long-term conditions? The answer is probably not either or, but finding the right balance between those different options. So far, the emphasis has understandably been on the first of each of these, controlling infection, dealing with COVID, and managing acute conditions. But it looks like we're in for a long haul. Data shows slow decreases in the first wave of infection, and we can predict recurrent waves after that. So we need to move towards more sustainable strategies. Now, every cloud has a silver lining despite this disaster. And the good news about this pandemic is that people all over the world are responding in creative ways, even though many of the most important facts about the pandemic are still unknown. And we've heard some of them today. For example, the example of trying to maintain access to services for people with renal failure, supporting people with dementia, their carers, and services for people with dementia. So this diverse experience of innovation and of successes and failures can help us find solutions that are effective, fair, affordable, and sustainable. And we really need to capture all of that diverse experience. So the challenge for us participating in this webinar is to continue to capture and share that experience and evidence, and then work together to find innovative solutions to the problems we've discussed today. Thanks, Janet.
Thank you very much, Max. So some additional points to consider there, and there have been another few comments in the question and answer. I'll just draw attention to one, which is the issue around gender. There is clearly a difference in between men and women in terms of deaths from COVID-19, but as the questioner mentions, there is obviously in many places a severe impact on women, often slightly younger women, but also older women, in terms of care and the risks that they face as being the unseen face of care in the home and sometimes support in hospitals. So Vivek, I think I'll give the three speakers 5 minutes to respond as you feel you want to on the comments put to you in the question and answers and Max's point. And then, of course, people can follow up afterwards, I'm sure, on email if we haven't got time. So 5 minutes each, please.
Thanks, Janet. So to the question about the number of palliative care facilities with relation to the number of households, if I understood the question correctly, Kerala has a population of about 35 million, and according to 2011 census, there were about 11 million households in Kerala. Now, we don't know the exact number of palliative care facilities, but it is estimated that there are between 800 to 1,000 palliative care facilities throughout the state, which would mean that there are approximately 70 to 80 facilities per million population. I have to say here that Kerala has pretty much of almost 90% of all the palliative care facilities that we have in India at this particular point of time. So that's just in terms of numbers. Of course, a lot needs to be ensured that the services that these palliative care facilities need to provide, for example, access to various drugs, including morphine, etc., is there, which is another challenge that the palliative care physicians continue to face in India. Now, to your comment about hydroxychloroquine, I think the data is now emerging that all the hype around hydroxychloroquine was perhaps really greatly overstated. India's decision to go out and share the hydroxychloroquine supplies with many countries were more to do with political diplomacy and medical diplomacy than real, expectation of hydroxychloroquine providing benefits. But of course, that remains to be seen, and there are randomized clinical trials ongoing, both for prevention of COVID infection in people who are at high risk, such as healthcare workers, and people who already have coronavirus infection. It needs to be pointed out that hydroxychloroquine is not without risk, and there have been several reports of adverse effects related to hydroxychloroquine use, including death. So my advice is for people not to go out and start using it unless we have much stronger evidence in one direction or the other. Now, I think what comes through very clearly is, and this point was made by Max as well, is what do you prioritize? And this is a choice between the devil and the deep sea, literally, is that no one should be asked this question, that we need to prioritize healthcare delivery. But of course, in our resource constrained world, that question is very legitimate. As a chronic disease physician, I know that even stopping care for some time is likely to have a long-term effect. For example, if a patient with diabetes or a patient with kidney disease interrupts his or her care for some time, it doesn't mean that once this current situation ends and that person is able to resume his or her care, his health or her health will go back to where it was before that interruption took place. So that's something which you have to keep in mind, that the effect of this interruption in care will continue to be seen for a long, long time in our societies. The other issue which we as healthcare professionals don't talk so much is about the issue of the interruption in their livelihoods and all of that is going to happen in their ability to access care, both for COVID infection. We didn't talk so much about stigma. In a country like India, we have seen really very bad examples of stigmatization of people who have coronavirus infection, and even healthcare workers who take care of people with coronavirus infection, and how they have been sometimes excluded from the society. There was a really upsetting story of a doctor who died with COVID infection, he contracted it during the course of his duty, and he was refused even a good burial service, appropriate burial service, which was quite disturbing, to hear. So I think there are a number of issues that this infection is throwing up, including fracture in the societies. We do talk about other issues. Someone brought up the issue of class. And again, there is quite clear data to suggest that ethnic minorities and deprived populations are at greater risk both of getting the infection and also of suffering adverse outcomes. Again, coming back to my country, we have large sections of our population who live in very crowded, difficult to live environments. They live in slums. Several people live inside one room. They don't have access to running water. So to expect them to be able to practice social distancing or physical distancing or even regular hand washing is not, should not be taken for granted. There are a number of these other issues which we don't often talk about. But like you said, there is always a silver lining to this huge dark cloud. And the biggest silver lining, in my opinion, in my country is that we are talking about health as an important priority, social priority. Health has always been in the back burner, as we all know that India is one of the lowest spenders on providing healthcare to its population, less than 1%. But hopefully, again, I hope, and this is a big if, that whether we will see or not any change in this situation once hopefully the current COVID pandemic recedes.
Thank you. Thank you very much. So let's move quickly to Moffat for his 5 minutes.
Hey, thanks very much. So I think, I've really enjoyed listening to everybody else. I think, as far as Africa is concerned, clearly we have so many transitions going on, at the moment, nutritional, epidemiological, and then we've got COVID. But in terms of the older people, I think we're going through a transition where in terms of how best do we support older people. So we still have the traditional structures, but increasingly there will be institutional support, but that's not there yet. So I think the first problem that we have, and that needs to get into prioritization, is actually identifying, how big the population is. So in most cases, we actually don't know. So we don't have that target number of individuals who are in this population. And that's a major thing. So my feeling is that there will be a lot of people just suffering the hardships in their rural areas and essentially well forgotten. So that's one element in terms of the metrics. And the other element, which I tried to highlight earlier on, is that the environment here entails that a lot of people actually age much faster. And so if that's the case, then we can't say, well, in the UK, the age that someone is particularly at risk is 60 or 70. We need to develop some metrics here. Otherwise, a lot of people will be left out and will suffer. We've gone through this in terms of other areas of biology. For example, when it comes to a BMI, we know that if you live in India, for example, you have a much higher risk of having diabetes or hypertension, even at a much lower BMI, to such an extent that people have advocated for their own cutoffs. So I think that will be the same when it comes to the hardships that people suffer from the aging process, that individual out here start suffering these consequences at a much younger age. So the bracket, I think, has to be defined with in a context specific fashion. But in general, I think the magnitude of the burden in Africa is going to be absolutely huge. You don't know where to prioritize because infection and the nutrition and other elements of poverty are just so rampant, and the health systems are not there. And at the moment, things have essentially collapsed, and there are no clinic attendances. So it's going to be really huge. I just don't know where one would start to prioritize. But I think, in my view, I would have thought that this is an opportunity to start recalibrating things in terms of identifying how big our population of older people is, and really understanding that it's not just going to be 50 plus, it has to be at least 50. So those are the issues that I would prioritize in as far as what we can contribute. But clearly, the magnitude of the problem in Africa is going to be phenomenal. Thank you.
Thank you very much, Moffat. And then to Suvana, please. Can you unmute, Suvana?
Sorry. Yes. So I'll take the question from a couple of questions from Penny and Kate. So thank you for your questions. And so the question is, how is telemedicine helping impoverished people in distant areas, and can it realistically reach these populations? In fact, we've been this is precisely what we've been thinking so much about over the last few weeks. NIMHANS, where I work, started its telemedicine services in 2005. So our institute has a fair amount of experience in telemedicine. It's a doctor-to-doctor telemedicine system right now. So you have to be a registered doctor at the other end. So, and during the during this pandemic, the kind of activities that have happened are to spread awareness among doctors, to train doctors on how to manage the crisis, to provide mental health support. Many of our psychiatrists and doctors are actually spending a lot of time with their patients on using the service. And the 2020 telemedicine guidelines for India are being developed along with the government of India from NIMHANS to make it as patient friendly as possible. I tried telemedicine for a person with dementia a few days ago. Very difficult to develop empathy, to express empathy. But if you look at the guidelines of American Academy of Neurology, people who've done it for some time seem to be able to do it. And I think this we will have to use telemedicine and to reach more and more people. And that has to be done systematically. So we will know with time. The second question from Kate, thank you for your comments. Yes, so you ask about healthcare inequality, if there are any gendered impacts that we have seen in our observations, how can we ensure that both older women and men can continue to access the ongoing healthcare and medication they need? Have you considered gendered impact on carers, especially older women who continue to shoulder disproportionate care loads? This is so true, and it's very sobering. And as I mentioned, we are unprepared for this, and our vulnerabilities are going to be exposed. And indeed, it's going to be the older woman carer who is going to face the brunt of it all. So I think, so when we develop care programs, we will really have to focus on the most vulnerable of the people, person with dementia, the older woman who's providing care for dementia. And yes, this has to be factored into our care programs. And I think some hope. In India with dementia, we were trying to develop a model for that would work. Would it be home care? Will it be day care? Do we need to set up more and more residential care systems? Will long-term care work? And when something like this happens really, and we see what works at times like this, culturally, what are our ways of life that are actually helping us? What might be a big risk for us to take? Do we have to set up hundreds of long-term care centers? So what this pandemic is giving us is some insights into what might work and what might not work. I mean, that's literally a very thin silver lining. So it will help us hopefully protect the most vulnerable in our population. Are there any other questions that I can see? Yeah, so my comment on potential cognitive impacts of COVID-19. So I brought this up because I'm a neurologist. People with COVID-19 can have seizures. They can have hypoxia. So they have reduced blood supply to the brain, causing stroke. They have reduced oxygenation of their brain. And if that goes on for some time, they can have some kind of cognitive deficits. It might not be because of the COVID-19 infection directly, but it's indirectly through its effects on the brain. So that is something that is known. There was a study from China, and they found a fair amount of people with very severe COVID infection having some neuropsychiatric residual deficits. Regarding long-term, we don't know. We just don't know whether it will produce long-term cognitive effects. SARS once did. We have no idea about this. So these are the questions that I think we can take.
Yeah, thank you very much, and your attention to the questions, I think, will make people who are posting them very happy. Unfortunately, we've got to the end of our time for questions. I think two critical things. One of the the points is the diversity of things to pay attention to in terms of non-communicable disease and older people. And I think one of the great concerns, particularly with lockdowns, is the deaths that we will never hear about, that Granny maybe, she has a stroke and simply is not taken even for the care. As Moffat said, some of the things that we're getting in place to address non-communicable diseases, we may be losing them. But I think we've had some hints from Vivek and from Savannah and from Max and also from Moffat of some of the positives, the thin silver linings of the fact that we are paying attention to health. And I think our responsibility, which everybody is shouldering who joins these webinars, is to bring the older people's perspective to the fore. So I shall hand over to Peter because I know he wants to wrap up with the last 5 minutes.
Well, Janet, thank you so much, and impeccable timekeeping, by the way, as well. Exactly 5 minutes. Yeah, I just want to very quickly do 3 things. Firstly, I just want to flag our forthcoming webinars. So the idea is to try and hold one every Friday, and we've already identified topics for the next 3 weeks. So next week, we'll be looking at care homes in low middle income countries with regard to coronavirus. And that will be, we're hoping it will be jointly organised with a separate network called the Long-Term Care COVID Group, organised by Adelina Comas, which has been very active in this area. As it happens, actually, we published a blog on our website yesterday about coronavirus in Kerala, and it includes a wonderful, positive and inspiring story about a particular response that's been taken by a government-run care home in the Indian state of Kerala. So you may want to check that out. It is on the blogs tab of our website. The following week, we'll be looking at lockdowns, and clearly that's something which touches on everything that we're interested in, and we've heard from Moffat about the positive effects of lockdown in Uganda, at least so far, in terms of controlling community-based transmission of coronavirus, and we've heard from all the speakers about the many negative effects in terms of access to treatment, stress and mental health of older people as well as people of other ages. So we're going to dedicate an entire session to this, and we're hoping that we will be able to take particularly a rights-based approach to this issue on the 8th of May. And we already have confirmed speakers from Human Rights Watch, HelpAge International and other organisations. So that should be interesting. A question just came through about what times these sessions are going to run. We're planning to run these sessions from now on at 2 o'clock UK time, every Friday, because we're very conscious that the International Federation of Aging is also organising some excellent webinars, which tend to start at 12 o'clock UK time and last for about an hour. So it is nice to give people an hour's break so they can rest their ears. On the 15th of May, we're going to look at pensions and social protection, and that will include the launch of a new edition of the HelpAge International Guidance on Pensions, which has already been quite widely applied in a number of low and middle income countries in terms of trying to reduce risks of infection and also possibly bundling in new kinds of interventions around the distribution of pensions to deal with problems caused by coronavirus. So please do keep an eye out for our forthcoming webinars. Next slide, please. Our previous webinar, as I already said, was on ageism. We've now, that led to a lot of interest. So we set up a special tab on ageism on our website. That included an invitation for people to complete an online form if they're very interested in this area and they wanted to play a leading role in developing these activities. I think to date, 20 people have responded to that, which is really, really good. Early next week, I'm going to email all of those people on the mailing list about what next steps will be taken. So some of those may be listening in now. If you are interested in this issue, there is still time to complete that online form. We do a weekly newsletter. Our next one will probably be going out on Tuesday or Wednesday, and I will also update about new developments in that area in the newsletter. Finally, last slide, please. Thank you. Thank you to everybody, especially thank you to Janet, who has done a fantastic job of managing this complicated session, and has really done a fantastic job. And I think the points she made at the end of the session were particularly useful and important. Thank you to Lucas for managing the logistics. And Lucas is currently writing up his PhD. He's doing a lot of teaching. He's doing many other things too. So the fact that he finds time to do this as well is really quite impressive. Thank you to our speakers. Thank you to our participants. And thank you so much to the many other people. I've listed some of them here. I'm sure there are others who haven't got around to listing, who are supporting the whole range of activities that we're developing on this platform. So thanks, everybody. Stay safe, stay well, stay sane, and hopefully see most of you next week. Goodbye.
Goodbye. Thank you very much.
Bye. Thank you, everyone.
Thanks, Janet.